So we are live and we can start.
Very good evening, my dear friends. This is Endocrine week, which is going on. Started yesterday, and now we're all through this. And yesterday we had a great beginning and went through the great speakers speaking about the recent things. Now, as a part of corporate program, we are today speaking about the early combination therapy of Linagliptin and Metformin. I am Professor Subramaniam KAV, Head of the Department of Endocrinology at King George Hospital, Visakhapatnam. So when we look at the diabetes mellitus, the prevalence is increasing. This is because of increase in the overweight and obese people throughout. There are various reasons which we are going to discuss at a later point of time. This increase in the diabetes mellitus, especially type 2, increases the prevalence of cardiovascular disease and associated comorbidities. And we also know that type 2 diabetes is a multi-organ and multifactorial condition with beta cell dysfunction and insulin resistance in peripheral tissues and the liver. And there is also defective incretin activity, as we are looking at the GLP-1 activity as well as the GLP-1 receptors. And there are elevated levels of free fatty acids because of faulty insulin action to prevent lipolysis at the adipose tissue. And of course, there are a lot of pro-inflammatory mediators which are supposed to increase the cardiovascular disease. And our type 2 diabetes is a progressive disease with deterioration in glycemic control over time and naturally with increase in the metabolic complications. So we need earlier intervention, so that you control glucose levels early, probably will control the complications, both micro as well as macrovascular complications. While the control of hyperglycemia remains the paramount and important goal, focusing on the underlying pathophysiology of type 2 diabetes mellitus is important with the aim of potentially providing the disease modification. For example, you are talking about if we have a drug where we can prevent the loss of beta cells, or we can postpone the loss of beta cells or apoptosis of the beta cells, probably patient will have better glucose control for longer period of time, which sometimes that happens in a genetically happy people. So looking at the prevalence of diabetes mellitus, now we have approximately 430 millions of diabetes people around the world. And our Southeast Asian region has the maximum, that is 82 million people. And by 2045, we are expecting 151 million in Southeast Asian region only. Approximately 77% of the people throughout the world are now living in the low and middle income countries like Southeast Asian countries. Of course, we along with China being the top 2 countries holding the number of diabetic patients. So coming to the Asian population, why we Asian population are having more incidence of diabetes mellitus looking at, there is a nutrition transition, sudden explosiveness. So the more and more, for example, you take 30 years back, the food availability itself is very less and the purchasing capacity of the people is very less. So naturally the type of food they could eat is very less. Whereas here now there is a nutrition transition where food is available everywhere and the type of food available also, though we say junk, it contains a lot of fat. And because of this rapid nutrition transition, people are developing overweight and obesity and consequently then diabetes. Of course, the socio-economic development has resulted in so many other things. Apart from the availability of good food, good nutrition, good clothing and good housing, it also made available the mechanic part of the thing, which made the people having reduced physical activity. You start from any persons. For example, a person who is going out for work. Previously, people used to walk to their fields, agricultural fields. Now they are going in a bike to the agricultural field. Previously, we all used to bicycle to the school. Now people are going on an auto or a car or a bike to the school. The same thing also is there. Of course, we Asians have a genetic susceptibility. All these reasons are important so that we all develop diabetes early and more and more. And coming to our own diet, the preferred diet is refined rice and wheat. And of course, this refined rice and wheat has high glycemic index and glycemic this one, and the glycemic load, that will result in increase in the postprandial hyperglycemia, and we know that the postprandial hyperglycemia is related to the endothelial dysfunction and resulting in cardiovascular diseases. So this is how our Asians, we are at a high risk of getting both type 2 diabetes mellitus and consequently postprandial hyperglycemia and consequently developing cardiovascular disease. And the pathogenesis, you all know this woman is Octet, and here we can concentrate on two things, most important being that we are also looking at the insulin production from the islet cells. Also, we are looking at the glucagon secretion is increased. Of course, our liver is having insulin resistance, and the peripheral tissue also insulin resistance with reduced glucose uptake. And of course, kidney is also incriminated now with increase in the glucose absorption. And of course, our incretin effect, and this is most important nowadays, the gut and the kidney are being now involved along with the brain in our management of hyperglycemia. So coming to our drugs, the therapeutic objective is threefold. One is we have to increase the insulin production from the beta cells. Or if we cannot do it, then give insulin from outside and simply exogenous insulin is there. And the other one is because there is insulin resistance, because of various factors we discussed, improve insulin sensitivity in the peripheral tissues. Then the liver is the metabolic house of the body, then increase the insulin sensitivity of the liver also. And these are the various objectives of any drugs being given, apart from reduction in the absorption of glucose from the gut and also increasing insulin, glucose excretion from the kidney. These are the various things which we are talking about. And coming to the management of type 2 diabetes mellitus, this algorithm most of us are looking at, and this is those patients with established atherosclerotic CVD or CKD. Here we have separate drugs, and we are going to discuss them now. But we are talking about treatment of a person with early disease, that's a newly detected type 2 diabetes mellitus, where the atherosclerotic vascular disease or CKD are not there. We are going to prevent them. Then we have after metformin. See, metformin is a first line of drug, we all know it from the last 30 years. And when the patient is having the more chances of having hypoglycemia, then probably the DPP-4 inhibitors, the GLP-1 receptor agonists, SGLT inhibitors, and thiazide and other drugs, which will prevent or minimize the hypoglycemia risk. Whereas the patient has uncontrolled hemoglobin A1C with these drugs and the other group of the drugs, and the hemoglobin A1C is still above the target, then we have to go for the other agents. So looking at the point is that most of our patients require multiple drugs. Here it's very clear that even our diabetic drugs, usually most of the patients will be receiving 2 to 3 drugs. For example, patient receives insulin secretagogue, patient receives insulin sensitizer should be given twice a day or thrice a day. Likewise, insulin secretagogue can be given once a day or twice a day or thrice a day. So almost you are talking about only for diabetes control around 3 or 4 tablets in a day. And also we are talking about adding other drugs, for example, other insulin sensitizer, or you are talking about adding an SGLT inhibitors. So the number of drugs patient will receiving will be somewhere. Sometimes you calculate, especially when I'm working in a government hospital, when I give individual drugs separately, almost the patient will be receiving around 10 tablets in a day for only diabetes. Leave about the hypertension, leave about the lipid control, leave about our other antiplatelet agents. So forget about these things. Only for control of glucose levels, we are talking about the patient having 6 to 10 tablets in a day. So coming from the reduction of hemoglobin A1C is so better, and it was shown that especially in Wikipedia, you can see that if there is 1% reduction in hemoglobin A1C, as simple as 1% reduction, even as low as 1% reduction, can reduce the risk of deaths from diabetes by 21%, myocardial infarction by 14%, microvascular complications by 37%, and peripheral vascular disorders by 43%. So this is how a simple single-digit reduction in hemoglobin A1C would reduce the amount of complications very nicely. This is a beautiful Wikipedia study. There you can see here the graphical representation with reducing levels of hemoglobin A1C. You can see the complications will come down drastically. So this is the average glucose levels, and this is hemoglobin A1C. You can see with the reduction in the glucose levels, you can see that the complications are coming down drastically. So looking at the challenges we face when you are treating the patients with diabetes mellitus. So we are looking at the parameters of carbohydrate metabolism and additional factors in relation to type 2 diabetes mellitus progression. So when you are looking at the parameters of carbohydrate metabolism, we have a stage in the pre-diabetes, then we have a diabetic stage, where here you can see with reduction in the beta cell function, which goes on smoothly down and down, there is increase in the glucose levels. And there is need for multiple add-on pharmacological interventions. And you remember when there is a need for multiple add-on pharmacological interventions, then the patient will have more chances of hypoglycemia. So the additional factors we have to look at when the patient is getting more and more drugs and more appetite, more weight gain, then of course, the most important thing is the cardiovascular risk goes up. And of course, there is increase in the diabetic complications also. So the paradigm in the several challenges in the treatment of type 2 diabetes is, one is to control the glucose levels. Then we are looking at the prevention of hypoglycemia and preserving the beta cell function without increasing the weight and preventing the cardiovascular complications and the other microvascular complications. So this is how we treat our patients, right? To treat our patients with type 2 diabetes mellitus, and they all need so many drugs. So looking at the ideal intervention, you can see first we have to improve the beta cell function, at the same time reduce the glucose levels. So this is the loop which is very much important. This will help in the reduction of hypoglycemia, and naturally this requires multiple add-on therapies. And that eventually results in the not of much weight gain, and of course there is a decrease in the cardiovascular risk and the complications. That's what we are looking at. So coming to the drugs, before talking about the metformin, once we have to remember that most of our patients, even you remember that days old, our treatment of tuberculosis, usually a patient requires 5 to 8 tablets in a day, and the compliance was so low that most of the times, most of the patients by the end of 1 month of treatment, people used to take only half the tablets. So there is a drastic thing which has made us very difficult to treat our patients and reduce compliance and the emergence of resistant tuberculosis bacilli. So with the introduction of combination of the fixed dose combination of these drugs, only 2 tablets in a day would make my day in those days of my practice when I gave most of my patients the fixed dose combination, and around 90% of the patients are compliant. So that's how the fixed dose combination resulted. And we have to have a method by which we have to have a combination of the drugs which have a complementary actions, and of course, they should not interfere with action of one another or the absorption. So coming to the metformin, which is the first line agent, of course, it's a 50-year-old molecule, my favorite. And I always say that we Indians gave this molecule to the whole of the world, though the molecule was invented there, they never used molecule to their full capacity. Ours is the only country where we are using this molecule for the last 40 years without any doubt of this molecule. And the current guidelines from both ADA, EST and all societies say that you initiate all the patients on metformin because it is the first line of the drug, and a combination also should combine metformin with other drugs. So if you look at the metformin, it primarily acts on the liver, and naturally it inhibits the hepatic glucose production. When hepatic glucose production comes down, the glucose levels get controlled. So when you treat the patients with metformin, always metformin's side effect is gastrointestinal side effects. So it's always better to start with the low dose and gradually increase the dose, and there's a linear dose effect relationship. So the most effective dose in reducing the hemoglobin A1C is 2000 milligrams, whereas the fasting glucose is 1500 milligrams. So this is the dose, and naturally minimum you have to give the dose drug 2 or 3 times. So in a meta-analysis, where the researchers from Medline, Embase and the Cochrane library, it was found that metformin monotherapy reduced hemoglobin A1C by 1.12%. This is almost equivalent to most of the drugs. And as I mentioned, the fixed dose combinations are the choice of the day, and because they have to have a complementary mechanisms of action, the low dose combination therapy compared to high dose monotherapy. So this is what is there. Previously we used to reach the highest dose of a single drug, then add another drug. But now we are talking about adding low dose of 2 drugs, then reaching a high dose of monotherapy, which might exhibit less of the effects, and whereas they can achieve similar or better glycemic control. So the advantages of fixed dose combinations are they reduce the number of the tablets, the frequency of administration, the flexibility of dosage administration, and minimize the treatment complexity, thereby improving the patient adherence. So the most important, especially you are talking about geriatric population more than 70 years, the number of tablets are so much, always there is a chance that they can forget, or they have a chance that they can take an extra drug also. So here also it is very much useful for the patients. So there is a systemic review where it was shown that the fixed drug combination therapy may have better adherence, improved satisfaction, and lower direct medical costs. This is what, when the two drugs are combined, we know that most of the times the price would be less than you combine both the drugs. So if you combine metformin plus DPP-4 inhibitors, you can see that the complementary actions. You can look at the pancreatic beta cell, pancreatic alpha cell. We are looking at the increase in the glucose-dependent insulin secretion and suppress the glucagon secretion. DPP-4 inhibitors comes into play, whereas naturally our metformin reduces the hepatic glucose production, and DPP-4 inhibitors also does it by increasing the insulin. And looking at the peripheral insulin resistance, metformin does it. When it comes to the safety and tolerability, low risk of hypoglycemia is seen with both metformin as well as the DPP-4 inhibitors. And of course, weight gain, you are looking at weight gain is lowest with the metformin and DPP-4 inhibitors. So with these, both the actions are complementary in almost all, looking at the all pathogenic mechanisms producing the type 2 diabetes mellitus. So coming to the DPP-4 inhibitors, the advantage being they can be orally administered when compared to other drugs which has to be given parenterally, and they improve the glucose tolerance and increase insulin release, and they're weight neutral. You can say some patients may have weight loss, but weight neutral most of the times, and the risk of hypoglycemia is very low. But the disadvantage is being sometimes, because we are inhibiting most of the DPP-4 enzymes, though they are specific to DPP-4, but sometimes they may inhibit other DPP enzymes also. So the target may lead to unwanted effects of immune function, especially patients may have more of nasopharyngitis, some people may have pedal edema, some people may have headache is also reported, and of course, you know that DPP-4 acts over the pancreas, and there is a doubtful chances of pancreatitis, and arthralgia is also reported because of immune dysfunction. So these are some of the side effects, proposed side effects of DPP-4 inhibitors, but I find gastric irritation is the maximum. So looking at the DPP-4 inhibitors, we have Linagliptin, we have sitagliptin, we have vildagliptin, and we have saxagliptin. So when compared that the hemoglobin A1C lowering efficacy of these drugs, and it seems they're almost comparable. Not much of difference between all these drugs. When they use the monotherapy or add-on therapy, then there is no much of difference. They're comparable. But you look at the bioavailability, of linagliptin is lowest, 30% when compared to sitagliptin, which is 87%, vildagliptin 85%, and saxagliptin 50%. But still, they have a comparable hemoglobin A1C reduction as far as treatment of type 2 diabetes is concerned. So the linagliptin was efficacious, safe, and well tolerated in Asian patients with type 2 diabetes mellitus and various degrees of renal impairment. So you can see not only so most of our patients may be having various degrees of renal impairment. Here they can be used without any adverse effects of like hypoglycemia, fluid retention, weight gain, and deterioration of renal functions. So you can look at linagliptin, which is very much efficacious, safe, though it has and can be given in almost all the degrees of renal impairment. And it was also shown that it an additional albuminuria lowering effect. So this is how we are looking at, and these albumin lowering effect is independent of alterations in the plasma glucose and blood pressure. How these drugs help? See, as far as incretin mimetics like GLP-1 analogs as well as DPP-4 inhibitors have similar antidiabetic efficacy, slight difference may be there, and whereas safety is concerned, tolerability is concerned, they score over the GLP-1 analogs. So when you combine them, they have complementary actions. Linagliptin inhibits the DPP-4 enzyme, thus prolonging the half-life of in the intestine secreted incretins, GLP-1 and gastric incretin polypeptide, thus improves the insulin secretion, whereas metformin improves the insulin sensitivity And the glucose lowering effect can be seen in the fasting state because it inhibits our overnight gluconeogenesis. And of course, metformin is also shown to have a GLP-1 production in obese patients, both non-diabetic as well as type 2 diabetic patients. So when you combine, this is one of the studies where it was shown that a 7-day crossover study has shown that the bioequivalent exposure and similar DPP-4 inhibition with linagliptin, whether used on 2.5 milligrams twice daily or a single dose. And when they looked at the bioequivalence of these 3 separate prospective randomized open label studies, they all showed that the single pill combinations of linagliptin plus metformin are bioequivalent to the individual tablets. So whether the linagliptin plus metformin are given twice a day or single day, the bioequivalence is same. And you can look at whether the food interfaces with the absorption of these drugs and changes of pharmacokinetics. It was another study showed that food does not have a clinically relevant effect on the administration of linagliptin and metformin single pill combinations. So the rationale is that they have a complementary actions, and metformin reduces the hepatic glucose output and improves insulin sensitivity and level of the muscle, whereas linagliptin increases GLP-1 levels and thereby stimulates the insulin secretion and inhibits the glucagon secretion. So this is how the synergy goes on. So this is how metformin reduces the gluconeogenesis and reduces the hyperglycemia, and linagliptin DPP-4 inhibition with increase in the insulin levels and suppression of glucagon. Of course, this is glucose dependent, so there is chance of hyperglycemia is less. So there is control of both fasting as well as postprandial glucose levels. So when you look at the combination in comparison with placebo, this is a beautiful study where it was shown that in a 24-week randomized placebo control study, where it was shown that the hemoglobin A1C is reduced by 0.64%, fasting 1.2 millimoles, and postprandial 3.7 millimoles per liter. And whereas when you look at the body weight, there is not much of increase, there is no change. That's what we can look at. This is a study where you can show at the various doses of monotherapy, linagliptin, metformin BD, metformin 1000 milligrams BD, a combination. Then you can see the reduction of changes in the hemoglobin A1C from the baseline is almost 17%. And this is an open label study where it is almost 3.7. So you can see, this is 1.7% and 3.7%. So this is an article where it showed, published in Diabetes, Obesity and Metabolism, the initial combination of linagliptin and metformin compared with linagliptin monotherapy in patients with newly diagnosed type 2 diabetes and marked hyperglycemia. This is in this randomized control and actively controlled trial, it was shown that linagliptin in initial combination metformin in patients with type 2 diabetes and marked hyperglycemia, you can see that there is significant improvements in glycemic control with low incidence of hypoglycemia, weight gain, and other side effects. So this is what it was shown, and this is another study which is published in the Diabetes Therapeutics. You can see that this is from Yaguanshi group, where they showed that early combination therapy with linagliptin, where they have taken 1,000-odd patients, treatment more than half had diabetes for less than 1 year, that is early patients. So you can see that the baseline hemoglobin A1C is approximately 8.7%. And here the controlled hemoglobin A1C percent 6.5% you are getting without hyperglycemia. So you can see that most of the patients, they achieved a hemoglobin A1C of less than 6.5%, having this beautiful response. So early combination treatment with linagliptin and metformin can increase the chances of achieving tight glycemic control, that is less than 6.5%, without increased risk of hypoglycemia and weight gain. So the place as far as species are concerned, single pill combination concerned, is that it provides a reduced pill burden, improved adherence. Better adherence often results in the better efficacy, and of course, it is cost effective because a combination, usually the cost of the drug by the pharmaceutical companies would be less. So with this, we can safely say that the goals of hyperglycemia management in our type 2 diabetes are to reduce hemoglobin A1C and to minimize the diabetic complications, and of course to avoid weight gain and hypoglycemia. The DPP-4 inhibitors have a complementary mechanism of action with metformin, and the combination will provide better glycemic control because with low risk of hypoglycemia and no additional weight gain. By addressing the core pathophysiological mechanisms of type 2 diabetes mellitus, the addition of DPP-4 inhibitor to metformin delivers comprehensive therapeutic advantages. With this, I thank you all and I thank Lupin for giving me this opportunity to interact with you. Thank you very much. Over to Amitabh.
Thank you, sir. So I'll be sharing my screen, sir. So at the outset, thank you, Lupin, for giving me this platform today. And thank you, my previous speaker, Dr. Subramaniam, sir, because you have made my job very easy, actually. So welcome all of you delegates who have managed time to listen to this scientific enrichment program on some of the practical aspects of diabetes management. So what I will be focusing on is a case-based discussion on rationale of or utility of combination of empagliflozin and linagliptin, the theoretical advantages of combining two drugs, or for that matter, combining an SGLT2 inhibitors and DPP-4 inhibitor has been already dealt by my previous speaker. But we'll also be taking you through a short theoretical discussion, you can say re-emphasizing on the advantages of EMPA-LINA combination in the second part of the presentation. So let us begin with the case presentation. So we'll be discussing a case of a college professor, Mrs. Kamal, who is 54-year-old female. She is diabetic for around 4 years. During routine checkup, she is complaining of generalized weakness. She had an hospitalization for acute coronary syndrome about a year back. She also had a family history of premature cardiovascular event. She is obese. Her BMI is around 30. She is also hypertensive, but her blood pressure is not under control. Her blood pressure is around 146 by 86 millimeter Hg. Her HbA1c is 8.4%. Her fasting plasma glucose is 165 milligram per dl and postprandial plasma glucose is 280 milligram per dl. Her LDL cholesterol is 75 milligram per dl. A 2D echocardiography done suggests an ejection fraction of 55%, but with slightly dilated left atrium and right atrium. She also has retinopathy, which is stable, non-proliferative. She has a sedentary lifestyle and do not want any further weight gain. In fact, a little weight loss will make her happy. She also complains of occasional symptoms which are suggestive of hypoglycemia. She is currently on sulfonylureas and metformin combination, glimepiride 4 mg she is taking. Metformin she is taking 1 gram twice daily. She is also on angiotensin receptor blocker, losartan 50 milligram once daily. She is on atorvastatin 40 milligram. Her antihypertensive also includes amlodipine 5 milligram, chlorothalidone 15 milligram, I think it should be 12.5 milligram, metoprolol XR 50 milligram and aspirin 75 milligram daily. So before we discuss this case, we need to understand what are the issues of concern for Mrs. Kamal and what are the issues for concern of the endocrinologist who will treat her, or for that matter, the stakeholder of diabetes management who will treat her. So Mrs. Kamal's concern are, she of course wants good glycemic control, like any of our diabetic patient, anyone and everyone wants it. She also is little bothered about her blood pressure. She does not want any further weight gain, and she wants to lead a hypoglycemia free life if that is possible, or she doesn't want to have the recurrent episodes of hypoglycemia. So let us see whether we can help her or not. The physician's concern for her are, of course, her concerns are therefore automatically becomes the physician's concern. There's no doubt in it. But apart from her concerns, the physician has some other concerns also. Like the physician is also bothered about that she being just diabetic for 4 years and being a 54-year old 54, 54 is nowadays, it is young. It is not even middle age. So since she's just 54 years and diabetic for only 4 years. So her physician is wondering what should be her HbA1c goal. Should he or she to target her HbA1c to 6.5% or less, or should it be 7%, or should it be 7.5%, or should it be more? So for that, we need to understand that the ideal HbA1c, though we all know this, that the lower the HbA1c, the lesser is the chance of microvascular complications like retinopathy, neuropathy, and nephropathy. Mrs. Kamal already has a stable non-proliferative retinopathy. So of course, this is an issue of concern for us that her retinopathy should not progress further. She should not develop nephropathy or neuropathy, which luckily she does not have still now. But then how low the HbA1c can go? HbA1c target should be 6.5% for someone who is not on insulin secretagogues and someone who is having a otherwise healthy profile, not having any other comorbidity, and the treatment should not incur extra risk of hypoglycemias. Otherwise, for almost all persons, the HbA1c target should be a little less than 7% if the person has long life expectancy, which is the case with Mrs. Kamal. So probably for her, the HbA1c target should be around 7% or slightly less than that. However, that may be a little difficult, seeing the comorbidities like cardiovascular events she has, and also considering the fact that she's also having recurrent episodes of hypoglycemia. But still, we should try to get her HbA1c to less than 7%. Currently, her HbA1c is around 8.4%. So you need to reduce her HbA1c by around 1.4%. And as you know, in diabetes management, we'll be discussing it in subsequent slides also, but no individual drug, even metformin also, generally do not offer you an HbA1c benefit above 1%. So it is clearly evident from her case that she needs at least 2 oral hypoglycemic agents over and above what she is receiving now. Or if she is convincible, then you can also consider basal insulin, but then probably basal insulin is not much required here. She can be easily managed with 2 oral anti-hyperglycemic agents, and for that matter, the combination of empagliflozin and linagliptin will be a lucrative choice in her case, seeing her BMI, which is slightly high, and because she also has a concern of not gaining further weight. In fact, she wants to lose weight. And also, considering the combination of empagliflozin and linagliptin can give us an HbA1c benefit of close to 1.5% and sometimes slightly more also. Second concern, which the diabetologist or the physician of Mrs. Kamal will be having, is her cardiovascular event, which has happened around 1 year back. So she also has a premature history of CVD in her family, in her father. For that matter also, addition of an SGLT2 inhibitor is almost must for her, because all SGLT2 inhibitors have been shown to be beneficial so far as cardiovascular event reduction is concerned. If we talk about empagliflozin precisely, then in fact empagliflozin has got most robust evidence of reduction of hard marker like cardiovascular death in patients who are having established cardiovascular disease. For this, for that matter, Mrs. Kamal has got established cardiovascular disease. She was admitted in hospital for acute coronary syndrome 1 year back. So she becomes a most ideal candidate to receive empagliflozin in that sense. And also, the combination of empagliflozin and linagliptin will be beneficial for us, beneficial for her, because linagliptin has shown in both CARMELINA and CAROLINA trial to be CV neutral and also heart failure neutral. Therefore, Combination of linagliptin and empagliflozin will be suitable for her so far as CV death reduction is concerned, so far as hospitalization due to heart failure reduction is concerned, and also so far as reduction of 3-point MACE is concerned, also so far as slight reduction of body weight is concerned, and her lipid profile, if you come down to her lipid profile, she is already receiving atorvastatin 40 milligram. So the SGLT2 inhibitor empagliflozin can have slight modest beneficial effect on her lipid profile also. In that sense also it is good. The SGLT2 inhibitor empagliflozin can reduce her systolic and diastolic blood pressure by maybe 2-3 millimeter Hg systolic and by 1-2 millimeter Hg diastolic. So that will also be a welcome point for Mrs. Kamal, because as you see, her blood pressure is 146 by 86 millimeter Hg. But as you know, for diabetics, we should target a blood pressure to less than 130 by 80 millimeter Hg. And in that sense, addition of SGLT2 inhibitor empagliflozin will only benefit her. But again, I will like to reiterate that she is getting losartan 50 milligram OD. So if her renal functions allow otherwise, we can also uptitrate the losartan dose to 50 milligram twice daily or 100 milligram once daily. Even that can be beneficial. Also, her empagliflozin in the combination of empagliflozin linagliptin will be beneficial for her so far as heart failure risk reduction is concerned. As you can see, her ejection fraction is 55%, though it is normal, but it is just at the brink of normal limit. And also she has slightly dilated LA and RA. So that will also be a welcome point, because hospitalization due to heart failure is clearly reduced with empagliflozin. Also, a combination of empagliflozin and linagliptin will be beneficial so far as nephropathy progression is concerned. As per the available data, they suggest that SGLT2 inhibitors are beneficial so far as CKD progression risk reduction is concerned. So as you know, our patient, Mrs. Kamal, has still not developed nephropathy. She has non-proliferative stable retinopathy. And therefore, it will be important for us to consider SGLT2 inhibitors like empagliflozin in her case, so that her nephropathy reduction is nephropathy risk reduction is concerned. So, so these are the issues which concern Mrs. Kamal. A brief recapitulation of effect of individual drugs: metformin, SGLT2 inhibitors, sulfonylureas, DPP-4 and GLP-1 analogs. They are the agents which are used in diabetes management, as you know. Metformin and sulfonylureas can cause an HbA1c reduction of around 1.5%. Metformin is generally considered to have slight beneficial effect so far as ACVD is concerned, but is neutral so far as congestive heart failure is concerned. It is contraindicated at eGFR of less than 30, and the dose should be reduced to half for eGFR of less than 45. The SGLT2 inhibitors are beneficial so far as ASCVD is concerned, congestive heart failure, that is hospitalization due to heart failure, is concerned. Progression of DKD is concerned. They are to be used extremely cautiously when the eGFR is less than 45, though you can use it till eGFR of 30, but then I will suggest that the renal function should be stable if you use it below eGFR of 45. The sulfonylureas, second generation sulfonylureas like glipizide, glimepiride, and gliclazide, they cause weight gain, but the weight gain is not very much significant. It is modest weight gain. They are neutral so far as ASCVD, heart failure is concerned, or progression of DKD is concerned. DPP-4 inhibitors and GLP-1 analog can cause an HbA1c reduction of around 0.8, sometimes a little higher, to around 1%. They do not cause hypoglycemia. GLP-1 analogs can cause weight loss, but then DPP-4 inhibitors are contraindicated for hospitalization due to heart failure. Not all DPP-4 inhibitors, sorry. Saxagliptin and alogliptin should probably not be used if the patient has got established heart failure, because in the trial, it has been seen, that is about TIMI-53 trial, it has been seen that saxagliptin has been associated with increased incidences of hospitalization due to heart failure. Similar result has been obtained in the alogliptin CV outcome trial also. Therefore, if the patient is having established heart failure with reduced ejection fraction, then it is always safe to choose DPP-4 inhibitors, which have proven their CV neutrality so far as heart failure is concerned in the CV outcome trials, and they are Linagliptin and Sitagliptin. So you can use either of the two. So treatment options of Mrs. Kamal, though we have discussed, there are two options which are relevant here. Either add a combination of SGLT2 and DPP-4 inhibitor, or add a basal insulin. I don't think there is a third choice for her. Yes, there can be a third choice of adding a GLP-1 analog, but then GLP-1 analogs are injectable and they are generally less preferred by the patients. So I am not discussing that. So nowadays, the American Diabetes Association and so far as all world bodies, all guidelines like AACE, European Society of Cardiology, they have now placed SGLT2 inhibitors immediately below metformin. In fact, the European one has placed it above metformin also, but that is something which is controversial, so let us avoid that. In all other guidelines, including the ADA 2020, SGLT2 inhibitors have been placed just below metformin as a second-line agent of choice. If the renal function of the patient allows, and if the patient has comorbidities like atherosclerotic cardiovascular disease established, or having high risk factors for atherosclerotic cardiovascular disease like angiographically proven, coronary artery disease, or in a patient who is having an age of 55 years or more, then probably you should actively consider adding an SGLT2 inhibitor to the patient, irrespective of HbA1c. That means if the patient is having a ACS history, like in our patient, Mrs. Kamal, then too you must consider adding an SGLT2 inhibitor, preferably empagliflozin, because the evidence is more in favor of empagliflozin. But then there are others also, irrespective of HbA1c. So let me make it more clear. Mrs. Kamal had an HbA1c of 8.4%. So in her case, there is no controversy that she needs an empagliflozin. But then what if the HbA1c was 6.5%? I will still suggest that, in fact, it's not I am who is suggesting, it's the ADA 2020 guideline which is suggesting that even at an HbA1c of 6.5, please consider putting Mrs. Kamal on empagliflozin, at least if she has an ACS history. So that's how it is being emphasized in the ADA guideline. Similar is the case of heart failure with reduced ejection fraction and CKD. If the patient is having an EGFR in between 30 and 60 and is stable, and have either and or having an urinary ACR particularly above 300 milligram per gram, then you should actively consider putting the patient on an SGLT2 inhibitor, irrespective of what HbA1c the patient has, because these SGLT2 inhibitors have proven their beneficial effect so far as ASCVD event reduction is concerned, hospitalization due to heart failure reduction is concerned, and CKD progression is concerned. The dysglycemia legacy, we have all seen this slide in almost all of the diabetes presentation. This is very, very important slide. This talks about early importance of early glycemic control. This is a very interesting slide which says that if the HbA1c of a patient is controlled to less than 7% within 1 year of diagnosis, compared to persons in which the HbA1c remains more than 7% and it is controlled after 1 year of diagnosis. So what happens is at the end of 5 years, in those persons who have been diagnosed, who have been intensively treated right from the diagnosis, and their HbA1c have been reduced to less than 7% right from the diagnosis, they have 67% relative risk reduction so far as MI is concerned, 51% for stroke, 64% for heart failure, and 62% for composite cardiovascular events. So that's something which is, very much surprising, that even 1 year of bad glycemic control increases the relative risk of this cardiovascular complications so many times. So that's the importance of early glycemic control. Also, early glycemic control is relevant so far as coronary artery disease is concerned. That has been proven from the study of prevalence of subclinical cardiovascular disease, which is seen in 70% of patients who is having diabetes and 30% of patients who is not having diabetes. The beneficial effect of empagliflozin so far as heart failure is concerned is also being reciprocated in the basic science level study, in which it has been seen that empagliflozin causes reduction in the LP mass index after even 6 months of use. That may be one of the explanation of why we see lesser incidence of hospitalization due to heart failure with empagliflozin. And since there is reduction in LV mass index, so probably there is risk reduction so far as arrhythmia risks are concerned. So that may be one of the reasons why we see cardiovascular death reduction is concerned so in with empagliflozin so soon after initiation of empagliflozin. In fact, the number needed to treat is very less, and in fact, the time required when you start a patient on empagliflozin and you start ripping out the dividend of reduction in CV death or 3-point MACE is very short. Even after 21 to 28 days of use, you start using empagliflozin in the group where you are using compared to in the group where you are not using. Now, CARMELINA and CAROLINA were the two landmark CVOT trials. CARMELINA was Linagliptin versus placebo, and CAROLINA was Linagliptin versus glimepiride. So Linagliptin becomes, after the completion of the CAROLINA trial, Linagliptin becomes the only gliptin in the world currently which has got not one but two CVOT trials with two different agents. One is placebo, placebo is not an agent, but one with placebo and another with an active agent like sulfonylurea or glimepiride. So linagliptin is one gliptin which has got most robust data sheet so far as CV neutrality is concerned. In both CARMELINA and CAROLINA, linagliptin has proven itself cardiovascularly neutral so far as CV death is concerned, non-fatal MI, non-fatal stroke is concerned, or hospitalization due to heart failure is concerned. In fact, in various across the board subgroup analysis, both in CARMELINA and CAROLINA trial, in all subgroups of patients, even in those who had previous history of heart failure, linagliptin has unambiguously proven its CV neutrality. In the CAROLINA trial, linagliptin has also proven lesser incidences of hypoglycemia compared to glimepiride, though that is quite expected. I don't know what was there to prove it, but then it has proven itself in the trial. So with this, linagliptin becomes a better gliptin evidence-wise because of more availability of evidence compared to other gliptins. So also we have now the data of Emperor reduced and trial with the empagliflozin, which has published recently in the November 2022. We will be getting the Emperor preserved trial data also sometimes, that is yet to come. We will be also getting the EMPA kidney trial results, which will come at around in the end of 2021. The EMPA kidney trial is a dedicated CKD renal outcome trial with empagliflozin, and the EMPA reduced trial was basically a trial which was done in patients with heart failure with reduced ejection fraction. So it was a trial which was primarily dedicated to see the outcome of heart failure, that is heart failure event reduction with empagliflozin compared to placebo. In this heart failure with reduced ejection fraction trial, the Emperor reduced trial, all the patients who were recruited were having less ejection fraction. In fact, 73% of the patients recruited were having ejection fraction 30% or less, and 80% of patients were having NT-proBNP, which is a marker of heart failure with reduced ejection fraction, 1000 picogram per ml or more. In fact, 48% of patients also had an eGFR of less than 60 ml. So the interesting point of Emperor reduced trial was not all the patients were having diabetes. In fact, only about half of the patients were having diabetes. So half of the patient did not have diabetes. So it was an important trial which extrapolated that whether empagliflozin can be used in patients with heart failure with reduced ejection fraction, even in those who were not having diabetes. So let us see the result. The primary endpoint was composite of cardiovascular death or heart failure hospitalization. The primary endpoint reduced 25% relative risk reduction in those who were using empagliflozin compared to placebo, irrespective of diabetes status. So that was statistically superiorly reduced. The secondary endpoints, that is total, that is first and recurrent hospitalization due to heart failure, were also reduced significantly in the empagliflozin arm compared to the placebo arm. So this shows that empagliflozin, so far as the heart failure with heart failure hospitalization reduction is concerned, or so far as composite of cardiovascular death reduction is concerned, acts irrespective of patient being diabetic. So that also emphasizes that probably the mechanism by which the empagliflozin reduces CV death or hospitalization due to heart failure is probably not directly related to the glycemic benefit which empagliflozin gives. It is something which is beyond that. Probably, as I was mentioning, the LV mass index reduction may help in hospitalization due to heart failure reduction and the reduction in the arrhythmia because of because of the fuel shift which happens by use of empagliflozin. We all know that with use of empagliflozin there is relative increase in ketonemia in the blood, and ketone bodies are favorable fuel for the heart. So this relative fuel shift probably drives the myocardial metabolism favorably and probably reduces the risk of arrhythmias, and that may be one of the reasons why cardiovascular death because of sudden death because of arrhythmias are reduced in empagliflozin compared to the placebo. So these are the clinical implication or rationale. Now the combination of empagliflozin and SGLT2 inhibitors also has pathophysiological explanation, because SGLT2 inhibitors are important so that they increase the glucose excretion from the kidney. In the omnious octet, one of the pathophysiologies of dysglycemia in diabetes is reduction in glucose excretion from kidney because of uptitration of the glut or uptitration of the not glut, uptitration of the SGLT2 receptors or hyperplasia of SGLT2 receptors in diabetes that happens in diabetes, because of which the glucose excretion from kidney is reduced. So SGLT2 inhibitor, they increase the glucose excretion from kidney. And also the DPP-4 inhibitor, they help in correcting the malfunctioning incretin axis by increasing the GLP-1 level and reducing in the glucagon level. So also the SGLT2 inhibitors, they slightly increase the beta cell insulin secretion, maybe by reduction in glucotoxicity. So maybe this omnious octet, at least 4 or 5 limbs of these omnious octets are cut if you combine SGLT2 inhibitor and DPP-4 inhibitor. There is slight reduction in insulin resistance also with the combination of SGLT2 and DPP-4 inhibitors. So out of the 8 legs of the octopus, 4 or 5 legs are cut by combining SGLT2 and DPP-4. So that's the benefit. Also, we have some added benefits so far as renal reduction is concerned, CKD progression, and systolic blood pressure, uric acid reduction is concerned. So these are the benefits. Combination of SGLT and DPP-4 reduces BP, body weight, cardiovascular outcomes, hospitalization due to heart failure, mortality, renal events, microalbuminuria, etc. Glycemia-wise also, the combination is very fruitful. The combination reduces HbA1c by 1.5% at least, sometimes even higher, 1.8 to 2% reduction is also seen. The combination of EMPA and LINA can cause HbA1c reduction of even 2%. It causes a minimum HbA1c reduction of 1.4 to 1.5 times though. So durable HbA1c response and hypoglycemia risk of empagliflozin is seen compared to sulfonylureas. Obviously, they are a better choice. As I was mentioning, systolic and diastolic BPs are also reduced. And with linagliptin as a combination, what better you can expect, because linagliptin also has shown to reduce the albuminuria progression. And so if you combine Lina with empagliflozin, definitely you are going to get a CKD risk reduction for your patient, because both these agents, particularly empagliflozin, is much more robust so far as CKD progression is concerned, and also linagliptin will be helping empagliflozin. So safety-wise also, they are safe. This is just a summary of EMPA-REG outcome canvas program and declared TIMI. As you can see, the empagliflozin is superior so far as HHF and CV death reduction is concerned, and also the 3-point MES and renal outcome reduction is concerned. These are not class effect, because in ertugliflozin, we did not see any benefit so far as 3-point MES is concerned. R2 could only prove itself non-inferior so far as 3-point MES reduction is concerned. So that indicates that this 3-point MES superiority is something which is not class effect, because there were some criticism like earlier there were some people used to say that since declared TME58 came, that dapagliflozin, they incorporated many healthy patients, relatively healthy patients who were not having a history of cardiovascular disease, and because of that declared TME58 patient, they did not had superiority so far as 3-point MACE is concerned. Otherwise, SGLT2 inhibitors has got, that it can be a class effect, the CV risk reduction. But then ertugliflozin Vertis CV trial, it incorporated all patients, just like empiric outcome. All the patients were having established CVD, but still they were non-inferior so far as 3-point MACE is concerned. So what I mean to say is empagliflozin has something special to deal with. It's not a class effect. Renal and CV outcome combination, which we have discussed. So, just to summarize: greater HbA1c reduction, lesser risk of hypoglycemia, early achievement of glycemic goal, added benefit of potential BP loss, slight BP reduction also. So thank you. The session is over from my side. If you have any questions, you can ask.
So, Amitabh, I think we have some questions there, or we don't have any questions.
Okay, sir. I don't
Let
think.
us see the chat box.
Okay. Till now, probably we don't have any questions.
Okay.
So organizers can step in and can guide us what to do.
I think, Amitabh, when you're looking at in your own practice, whether you write this combination of linagliptin plus metformin.
Yes, sir. Yes, sir. I'm writing. I'm writing it very often, I think.
No, the thing is, see, we don't have. We don't have a 10 milligrams and 1000 or 10 milligrams and 5 milligrams and 1000 or 5 milligrams of 500. We don't have, no. We have only 2.5 plus 500 or 2.5 plus 1000.
Yeah. Yes.
The combination is there. So, see, whether if they come out with a combination of 5 plus 500 or 5 plus 1000, it would have been better, no? The number of pills would come down.
That would be okay.
And probably the cost may also come down.
Yeah, cost may also come down, sir.
So that's what I'm looking at.
So 2.5 by 500 is actually the price is half of what the standard linagliptin 5 milligram is. Almost half. But that is 2.5 milligram.
The price is not half, no, 37 rupees. The other one is only 54, no.
Oh, 37. Okay, I was knowing it 27.
So what I requested them is to come out with a combination of 5 plus 1000 and 5 plus 500. Yeah, the other brands are there, but they're coming with a combination of not a single pill. You look at the sitagliptin plus metformin, they're coming with 2 tablets in a single strip.
Yeah.
Whereas the other brands, they have combination.
That's not an exact combination, but they are separate pills.
Yes. So actually, now they have linagliptin plus empagliflozin combination. That is a good hit. See, the combination is cheaper than the individual drugs.
Yeah, that is actually cost effective. That saves around 20-30 rupees for the patient per day.
Definitely, that is much more, around 30 rupees cheaper than the original. If you use 2 tablets.
2 tablets.
So that I use more.
Yeah,
I prefer for all my patients, because that would reduce the cost burden very nicely.
Yes, sir. True, sir.
So if there are no questions, I think we can close the session, because almost it is 6 o'clock. So we have to join the other Endocrine Society meeting.
Okay.
Thank you, Amitabh. Thank you for the very good presentation, and I thank different people from my side and Amitabh's side for giving us this opportunity to discuss amongst others.
Thank you. Mr. Minto, we can